Good evening to everyone that has joined us for this EUS-GE webinar on endoscopic ultrasound guided gastroenterostomy. I'm Schalk Van Der Merwe from the University Hospital in Leuven in Belgium, and it will be my pleasure to be moderator tonight. There will be two speakers that will address us on this topic. We are very fortunate to have two of the absolute world experts, authorities that will discuss EUS-guided gastroenterostomy with us. The first is Professor Manuel Pérez-Miranda. Manuel is from the Hospital Universitario Rio Ortega in Valladolid in Spain. Manuel is well known to all of you as an expert in endoscopic ultrasound in various topics surrounding that, and he will address us on the issues related to how EUS should be performed, how the skill in EUS-guided gastroenterostomy can be acquired, taking us through a very systematic approach based on a very well-known recent paper that he published. The second speaker will be Professor Marc Barthet. Marc is from the Hospital Nord in Marseille in France. And Marc will kick off the webinar, and he will address us in how EUS gastroenterostomy should be performed, including the various techniques that we have available, the indications, the potential complications that one may see with this procedure, and how to remedy them. So I think we're very, very fortunate to have these two excellent speakers, and I welcome all of you to this webinar. I also, just before Marc starts, I want to draw your attention to the EUS-GE days that will be very soon, and remind you that there's the early bird registration deadline will expire tomorrow. So people that still want to come to the EUS-GE days, please remember that the deadline for the early bird registration is tomorrow. So without further ado, I'm going to ask Marc to address us on this topic. Marc, thank you very, very much, and we look forward to this talk.
Okay, thanks, and thanks, Schalk, for this nice introduction. And so I will speak about technical issues. So you know we have actually three different techniques. Direct technique, I will speak about, the WES technique, wireless endoscopic simplified technique, and the technique with balloon, which is called EPAS. You have everything in the recent guidelines from EUS-GE. And so the actual gold standard technique is a WES technique. And so I'll show you this short video. So it was in gastric outlet obstruction, malignant gastric outlet obstruction. And you see you put the guide wire inside the second and third duodenum until you reach the trace angle with the guide wire. And after you push a nasobiliary catheter inside the trace angle, and you fill with saline, with contrast, and sometimes with methylene blue. And so now you see you use hypokinetic drug also. And after you can start the WES technique, you see pushing directly the LAMS device inside the lumen, exactly in the axis. You open the distal flange, and after you pull back a little bit the flange towards the jejunum mucosa, and after you release the proximal flange. I release the proximal flange under endoscopic control, but you can do that in your operating channel. It's the same. It's a question of use. And after everything is done, and you have just to retrieve your device, and the patient can eat the day following. The EPAS, we have the first publication from Ito in Japan. I think this device is not yet available in Europe, and he published recently a study comparing with duodenal stenting and surgical bypass. EUS-GE did not recommend any technique over another one. So I will speak about the direct technique with guide wire, which was the first technique and which was the more difficult. And actually, we use technique only when we cannot use the West technique in modified anatomy and tight stenosis. So I show you the first video. Sorry for the title in French. It was in patient with previous pancreaticoduodenectomy and recurrence, and you see the obstruction of the small bowel at the level of the recurrence. So we try to find the small bowel, which was flat, of course, because it was downstream to the obstruction. And so you see you push a 19 gauge needle inside the small bowel, and the difficulty is to find the lumen and not to have the tip of the needle embedded in the mucosa of the jejunum. So you have to move the tip to be sure you are free, and after you can inject some contrast to have a clear delineation of the small bowel. And after, the difficulty is to push the guide wire, but to push the guide wire without pushing away the small bowel. This is what is very difficult, and you have to use, of course, hypokinetic drugs. We use a glucagon technique, and after over the guide wire, you push the axial stent, the lamp stent. But you see, when you push it, after you cannot see anything. So you have to be sure you are clearly in the lumen, and this is less clear than with the West technique. And after it is the same, you pull back gently the distal flange until you reach the lumen of the gastric side with the proximal flange, and after you can release the proximal flange. So this technique is efficient, but more hazardous than the West technique. I'll show you another indication, which was Crohn's disease. So the patient has a complete obstruction of the duodenum. He underwent 6 surgical procedure on the small bowel. So the surgeon told me, we cannot do anything, so try to do by yourself. And I did. You see the direct technique, pushing some water, you see, actually is the same than West technique, but you inject the line and we contrast directly with the needle, and after over the guide wire you push your device and you release it. This is the release of the distal flange, okay, and of course after you release the proximal flange. Okay, so this is the same than the previous one. I show you the result 1 month later. It was the Crohn's disease. Most benign indication are Crohn's disease and chronic pancreatitis for benign indication. And you see, after you can pass over, and you see a lot of injury of the small bowel due to the Crohn's disease. We have a comparative series we published with Laurent Monino, and this is a multicentric study. And you see clearly that the West technique decrease the rate of adverse events and also increase the technical success. So as you can do West technique, do it. It's better than the direct technique. And you see why? Because you have more misdeployment with the direct technique. And so the salvage therapy is mostly stent-in-stent technique, but the complication were mild technique. You see agree 1 and agree 2. This is a rate of adverse events of EUS-guided gastroenterostomy. You see about 10%, and most of them are stent misdeployment or dislodgement with the predictive factor, which is distance between the gastric and intestinal lumina. So we have now classification. You see you can have fatal in 2% cases of complication. And you see the type 1, which is the most frequent, with the release of the distal flange beside the gastric wall. So you can release the stent and close with OTSC clip. Sorry. The second one is more serious because you have a hole in the small bowel. It's a dislodgement of the distal flange. This is usually for surgery or not. And the third one is also very severe, but very rare, and also for surgery because the stent is stuck into the small bowel and out of the stomach. And the last one is a gastrocolonic anastomosis. I show you just an example of rescue. And the most technique we use frequently is the The stent is a technique. It was a patient with previous duodenal stent, and we have a dislodgement of the stent. So we add the guide wire, the rescue guide wire in the stent, and we push over the guide wire a fully covered metal stent, which was a TTS stent. And you can see now with the CT scan, you see the stent in stent visualization without clinical effusion or complication or pneumoperitoneum. And you see 1 month later, you can go very easily in the small bowel. The last one is of direct technique, so not gastrointestinal anastomosis, but gastrogastric anastomosis in case of edge. So you see, this is the direct technique. So you pass with a needle inside throughout the both gastric walls, and after you inject some contrast in the excluded stomach, after you push your guide wire, and after over the guide wire, you do the technique. Some of us are putting only some contrast, and after doing directly the West technique, not over the guide wire. You can do what you want. You have just to be sure you will not have any false tract when you are opening the flange. You see the opening of the distal flange in the excluded stomach and the delivery of the proximal flange into the remaining stomach. Okay. So of course, you know the recommendation of the guidelines of EUS-GE. You have to wait at least 7 days before passing through the stent because of the risk of dislodgement. So we have many studies only looking for the study. Indication are mostly biliary stones, and you can pass in half of the case through the stomach and half of the case through the jejunum at the level of the gastrojejunal anastomosis. And we have also this international study with a rate of complication, you see 15%. You have to know that because of bleeding, stent misdisplacement, or stent dislodgement. So 2-step and not 1-step, and use 20 millimeter lamp stent and not 15 millimeter stent. So this is my conclusion. So you see everything is possible. The two technique, West and the direct technique, are you can use it, but the West technique is safer and more efficient on a technical point of view. And you will see with Manuel that lamps are challenging duodenal stenting and lap surgery, but the procedures require experience and skillness and should be improved for safety. So thank you.
Thank you so much, Marc, for that very nice introduction and overview. I think that we will allow Professor Pérez-Miranda to proceed with his talk, following which we will have some discussion between the panelists based on the questions that you pose. So we invite people to pose questions that we can then also discuss in the session. So I now call upon Professor Pérez-Miranda to address us, Manuel, on the way in which you perform the technique, how you've standardized the technique, and how that can be applied in individuals that want to learn EUS-guided gastrojejunostomy.
Thank you, Schalk. It's really an honor and a pleasure to be here. These are my disclosures. And I'm going to talk about learning curve, indications, and outcomes. What do we really know about the learning curve of gastroenterostomy? What should we know, and how to get started? Well, if you query PubMed about learning curve and gastroenterostomy, 183 hits come up, but all of them have to do with robotic or laparoscopic surgery. If you ask more specifically about EUS-guided gastroenterostomy and learning curve, only 2 studies come up, and it's just a procedure time analysis, a QSAM analysis of a single operator using different techniques. In the first study, 33 patients who underwent gastroenterostomy over a 5-year period using the direct through the scope fluid infusion technique and with the lamps placed freehand. the mean time of 36 minutes plateau at the 25th procedure and decline at the 40th procedure. And a very similar procedure time analysis on 23 patients over 3 years with a mean time of 88 minutes using a different technique, the direct needle puncture with the LAMS placed over the wire, had very diverging results. The efficiency was reached at the 7th procedure. So 25, 40, 7, that really doesn't mean a lot. This is not very helpful. What we really know is to deconstruct the process of gastroenterostomy and find what are the process measures, the outcome measures, and assess them prospectively in a significant number of trainees. So what are the challenges? First, to identify the small bowel, because it is a very small structure, it's mobile, it's filled with air. Also, what is the right segment? Even can it be the colon, which sometimes is very close? So this is the first challenge. And for that, historically, the wire-based techniques, like using a balloon that could be clearly identified on EUS as the target, were first developed. So here are the 3 wire-based techniques that are mostly of historical interest. The balloon is punctured, then a wire is passed over which the stent is placed. Alternatively, the guide wire can be retrieved and pulled out of the patient, and with dual traction, the stent is placed over the wire, or an endoscope threaded over the wire. So these techniques are very cumbersome and have largely been abandoned. The fluid-based techniques that Dr. Barthet presented and are currently used, basically we need to create a very obvious target by fluid distension, and these are the direct technique. We puncture and then we infuse fluid through the needle, or with a gastroscope passed across the stricture, and no other device is used. The nasobiliary tube technique and the double balloon tube technique that Dr. Barthet mentioned, where a parallel tube along the echo endoscope is used to infuse fluid into the target small bowel under real time. And these are the currently used. So when we have a well-distended target, freehand insertion of the catheter into the small bowel is the dominant strategy. As you've heard, the proximal flange can be deployed inside the echo endoscope, which is the commonly used techniques these days by most operators. Also, endoscopic monitoring, the classic technique, is possible. And finally, it's important to check for misdeployment, which is usually done by the endoscopic appreciation of fluid return into the stomach. These last 2 steps are less controversial. In the first 2 steps, some authors add, like, should we use an FNA needle to puncture the small bowel and aspirate methylene blue or inject contrast? Or once the LAMS is inside the small bowel, should we use fluoroscopy with a guide wire or a contrast before deploying? So the combination of different preferred steps gives rise to a number of acronyms that are a bit confusing, but the important thing is to know about the steps and what are the challenges. And you want to start doing this very useful procedure in your department. How should you do it? Of course, this is only for fully trained operators in ERCP and interventional EUS. I would say it has to be done at middle to high volume centers, so with an individual procedure volume of 4 cases a week, that's 200 a year. And then you need to have familiarity with LAMS in on-label indications. I mean, gallbladder, bile duct, pancreatic collection. So you're not going to use a LAMS for the first time to do a gastroenterostomy. And I would say even more the exact same type of LAMS that you use. The gold standard LAMS is the Axios, which has 1 centimeter saddle, but there are also the 2 centimeter Spaxus is also available. The delivery catheter is different, is not as operator friendly. However, recapture of the distal flange is possible, so some pros and cons. And this device has a different lumen opposing force. In this ex vivo experiment, in which two pig organs were anastomosed using all three types of lamps, and then there was traction, and the force at which the two organs came apart was measured. I'm sorry about this. So Axios was clearly overall superior in opposing force to the Spaxus and the Nagy stent, but interestingly, in the gastrojejunal anastomosis, they came pretty close. Indeed, this Spaxus stent has been used in animals, a porcine model of gastroenterostomy, showing it is feasible. And we also have a very recent pilot study from Italy with the newest version, which is the hot Spaxus, in 25 patients with a technical success rate of 100%, procedure time 35 minutes, and very good outcomes over the long-term or mid-term follow-up. But if you're going to use this stent, you have to use it in other targets, because the penetration, pushability, all the features might be different from what you're used to. So more specific requirements, you have to study online material, talk to experts, attend webinars like this one. Hands-on in animals models is very appealing. However, the people who attend animal model labs are usually not the expert at high volume centers. So there's a discrepancy there. So I would say that today is no longer acceptable to have someone start by themselves without supervision, proctoring, or these days, gastroenterostomy is disseminating very rapidly. You can arrange as an observer at a nearby expert center, or even you can bring your own case and do it under proctoring. That is allowed in Spain at your referral center. And then finally, telementoring. So that is when you're going to do your first case solo, you can call your expert mentor, and he or she can guide you step by step. And the other alternative, instead of going through all these very labor-intensive or resource-intensive steps, just wait for a couple of years. Maybe this new device will become available. It will turn gastroenterostomy in a foolproof procedure. So this is a double balloon tube that fits the endoscope working channel. So it can be used in a therapeutic endoscope. The cap here is detachable, and then you can inflate the two balloons and distend the small bowel, and basically the small bowel becomes a pseudocyst. So, but this device is not yet commercially available. So how about the indications and the outcomes? There's one major indication, gastric outlet obstruction, and three variant indications. So overall, technical success in the first meta-analysis, around 300 patients, 90% success. And usually there is a good correlation with clinical success. It is not perfect in prospective study, but this meta-analysis includes mostly retrospective studies. And then the opposite 10% usually end up having complications. In this study, 12% complication rate. And as explained by Dr. Barthet previously, adverse events are usually related to misdeployment. So one is able to realize and fix it immediately. If your catheter is still inside the small bowel, you can pass a wire and breach with the SEMS, as we've been shown. Alternatively, if the stomach is clean and the distal flange is in the peritoneum, you can dilate, aspirate the jejunum up front with contrast, incise, put a wire, and do lamp salvage. Even this has been reported with the echo endoscope when using a 20 millimeter. So you save the endoscope exchange time. You can remove your gastroscope, balloon dilate the 20 millimeter lamps up to 15, past the echo endoscope into the peritoneal cavity. If you still have your nasobiliary tube in place, you can check, distend the bowel, and under EUS, you can pass a second LAMS. So this is similar to the first human experience using notes reported by Dr. Barthet in 2015. So how about more delayed adverse events? So 24 hours later, some patients may develop worsening of gastric outlet obstruction. This is thought to be caused by angulation, as shown here. In this case, a SEMS was placed through the LAMS and the patient recovered oral tolerance. So we have the same case just this week. We thought the previous duodenal stent was pressing on the efferent limb after the gastrojejunostomy. And if you look at this video, there is angulation. We're going into the efferent limb, into the good one. However, even if we are looking into the efferent, all the contrast goes back towards the duodenum. So in this case, what we did is put a wire, and you see the angle, it's a 90-degree angle, and that's what is causing the outlet obstruction. By using an esophageal tubular fully covered SEMS, the angle changes, and that patient today had a perfect oral tolerance. Very uncommon. I've only seen this once and seen a couple of reported patients, but it's very easy to fix by using a longer fully covered SEMS. The most common cause for stent dysfunction is food impaction. That can be very easily fixed, cleared by endoscopy. There is sometimes overgrowth with long-term angulation. That can be fixed by placing another SEMS inside, and more adverse events related to long-term indwell ulceration, usually asymptomatic, and fistula. I don't know what the risk factors for that may be. Maybe patients on chemotherapy, like we learned for colonic stenting. In these two reports, there was antral location, longer dwell time, or maybe lambs with softer flange will have less prone to these very rare, very uncommon adverse events. Finally, a very unusual cause of long-term stent dysfunction, the stent becomes embedded and completely buried. We can identify by EUS, put a wire, and bridge with SEMS. Finally, very rarely, perforation. This is a patient with chronic pancreatitis resulting in severe peritonitis, has also been reported. So what about specifically malignant gastric outlet obstruction? The EUS-GE guidelines recommend gastroenterostomy as an alternative to enteral stenting or surgery. So we need to look at the pros con relative to these two alternatives, and then discuss what is the threshold for the indication. Compared to enteral stenting, the most important difference is in the recurrence rate, and the need for reintervention in gastroenterostomy is 4% versus almost 25 to 30% with enteral stents. This is the first retrospective study, just 80 patients, but believe me, the numbers go up even 10 times. This is a recent meta-analysis, and it does stay the same. The proportion does not change. 4% long-term dysfunction. We have a recent, after these meta-analysis, the very recent randomized trial published this year, and about 50 patients. This is the patency for duodenal stent and the patency for gastroenterostomy. So definitively a much better long-term. How about surgery? This is the best retrospective study, 77 patients with gastroenterostomy, EUS-guided, 48 laparoscopic, and then there was significantly shorter time to oral intake, 1 day versus 3 days, and to a full diet, 2 days versus 8 days. Also, significantly lower rate of adverse events, 6% versus 31%, and shorter procedure time, 51 minutes versus 95, and hospital stay, 4 days versus 8 days. And again, in the recent meta-analysis with much higher number of patients, they're all in agreement. So even if we don't have a prospective study, palliation of malignant gastric obstruction with EUS-GE is much better than with surgery. Should we have a So what's the indication? Should every patient with primary malignant gastric outlet obstruction should undergo EUS-GE? That's the practice in our institution and in many others. But maybe if you're still at an institutional level, not fully developed, maybe you should initially reserve these for patients with duodenal stent dysfunction. Maybe we should have a higher threshold in patients with a very limited life expectancy, ascites, or other contraindications. However, in this recent multi-center Spanish study, we assessed quality of life prospectively at baseline and at a 30-day follow-up, which is very sharp. And we not only found significantly improvement in nausea, but also pain, appetite loss, and constipation. So even in patients who have a very limited life expectancy, there is improvement in quality of life. So how about the presence of ascites? The EUS-GE guidelines consider these contraindication, especially if the amount of ascites is significant or is refractory. Also, gastric linitis, plastica is a contraindication. And this is incorporated into very recent algorithms. So in some centers, even if they use primary gastroenterostomy for palliation, if there is ascites, or they go for enteral stenting and they reserve gastroenterostomy for patients without ascites. We have a retrospective study from India in which 12 patients with ascites underwent gastroenterostomy when compared to 19 patients without ascites, and there was no different technical, clinical success, procedure time, or adverse event. Obviously, patients with ascites had a much shorter survival, and antibiotic prophylaxis should be enhanced in patients with ascites. And again, this is one of our cases with gastric extensive linitis in gastric body, also stricture in the third duodenum, but we could anastomose the third duodenum to the jejunum and create a duodenojejunostomy. So there's ways you can get around certain contraindications. I would say a lower threshold for gastroenterostomy can be considered for patients with concurrent malignant biliary obstruction. This is the classical way from 20 years back when enteral stents first appeared. It's called the intraluminal approach to double endoscopic bypass. This is technically a tour de force, and more importantly, the outcomes are not so good. The transpapillary stent drainage is interfere with the duodenal stent, and the opposite is true. So we have the second generation double bypass, this patient with severe infiltration of the second duodenum presenting with gastric outlet obstruction underwent stenting and choledochoduodenostomy, but yet the patency of choledochoduodenostomy in the setting of gastric outlet obstruction is not that good compared to hepaticogastrostomy. Indeed, this was nicely shown by this recent retrospective study in which several combinations of double endoscopic bypass, enteral stenting with transpapillary stenting, choledochoduodenostomy, or hepaticogastrostomy versus gastroenterostomy with the same. And clearly, gastroenterostomy with hepaticogastrostomy is the winner, followed by gastroenterostomy with transpapillary stenting. So choledochoduodenostomy in yellow here, even with gastroenterostomy, is not that good. Definitely, it's much worse when duodenal stents are used. So in a patient with malignant obstructive jaundice, gastroenterostomy should be favored. And indeed, with this latest generation, this is a virtual who is who in interventional endoscopy, 154 patients underwent double bypass. surgically or with EUS, 53 with EUS, 100 with surgery. And again, outcomes are comparable regarding success, technical and clinical. However, with EUS, adverse events are significantly lower with a significantly shorter time to oral intake and shorter hospital stay. So this applies in this study to hepatogastrostomy, surprisingly fewer patients than with choledochoduodenostomy, even if we know that choledochoduodenostomy is not that good. How about benign gastric obstruction? It's also endorsed selectively in patients with refractory benign who are poor surgical candidates by guidelines. Typically, these would be patients with pancreatitis, necrotizing pancreatitis, or chronic pancreatitis and portal or splenic vein thrombosis that are malnourished. And traditionally, you would treat these. You cannot treat these with a duodenal stent. It's usually managed with tubes, PEG jet, NG tube, and nasojejunal. But with gastroenterostomy temporary, we can feed the patient and then 2-3 months later pull back the axios or the lamps, and the patient recovers. So most of these patients have pancreatitis, 50%, other anastomotic, caustic injury, peptic stricture. We have relatively good outcomes over 6 months. And then when the stricture goes away, which happens in a lot of patients with acute cases or with peptic stricture that can have oral treatment, oral antibiotics and PPIs, and then 80% of the patients, the lumps can be removed. Only a few of them can undergo surgery, need to undergo surgery. But even then, their nutritional status can be improved temporarily before surgery with gastroenterostomy. And then afferent loop syndrome, the best treatment is EUS gastroenterostomy compared to the traditional approach. So we can see, we can decompress the afferent loop into the antrum or duodenum, and compared to enteral stenting, the complete resolution of symptom is achieved 90% of the time, which is significantly higher with luminal stenting, and the need for reintervention is only 16%, which is significantly lower than the 76% in enteral stenting. Transjejunal ERCP, we've heard all about EDGE from Dr. Barthet, which is cost-effective compared to enteroscopy or laparoscopy-assisted ERCP. A similar approach can be used in patients with bilioenterostomy that need iterative management, like stricture dilation, removal of hepatolithiasis, stent placement and stent removal, with a shortcut between the duodenum or the antrum into the afferent limb. This is much simpler. The largest experience comes from Milan. Very high success rate, 97%, with acceptable morbidity under 20%. With a 3-year follow-up, the stricture recurrence is very low because much more aggressive using a therapeutic gastroscope through the lumps can be done. We can use SEMS, which is not possible with an enteroscope. And again, the recent update from Mutignani and co-workers from Milan, with a much higher number of patients, the same good outcomes are available. So we have a smaller series from the US. And finally, malignant small bowel obstruction, I just want to mention, but in patients with peritoneal carcinomatosis, gastroenterostomy or enteroenterostomy or even coloenterostomy can be done. This is still experimental, but might be useful in patients with downstream obstruction after gastroenterostomy. Only one series, 10 patients, 80% technical success, 70% clinical success, 1 death aspiration post-procedure, and 50% of the patients require additional procedures. So this is still a very experimental or remote. So in conclusion, EUS-guided gastroenterostomy with lamps is feasible and reproducible. It's a technically demanding procedure, requires expertise, attention to detail, and careful patient selection, superior outcomes to duodenal stent and surgical bypass in malignant gastric obstruction have been demonstrated, an improvement in quality of life. It is potentially applicable in selected patients with benign gastric outlet obstruction, is the best available option for afferent loop syndrome, and it facilitates biliary access in surgical anatomy, although we have much more data from EDGE than from ED. Thank you very much for your attention.
Thank you so much, Manu, for that excellent overview. I think you really took us through the steps in detail and showed us the possibilities. And thank you also, Marc, for your excellent videos to show the details and how you perform these procedures. So I think in the next few minutes, I would like to address a few questions that were posed to us by people watching. But maybe we can just take one step back. I think you very aptly showed how the procedure should be done, from the insertion of a guide wire, filling the small bowel. But Marc, maybe you can take this question. Have you got tips for the audience how to find the small bowel loop that you are targeting? What do you actually look for? Can you give us some tips regarding that?
Okay, so you have to combine the position of the scope, of the US scope, on X-ray and on US image. So usually with US orientation, you look to the body of the pancreas, and when you are close to the field of the aorta and the celiac trunk, usually by rotating the scope in a clockwise position, you find the trace angle, meaning that you have the fourth duodenum close to the gastric wall. This is usually the position. And if you look to X-ray, you have your EUS scope, which is straight alongside the vertebra. And normally, the position is about 45 to 50 centimeters on the left of the vertebra.
Okay, so that's a very important point.
Yeah,
very important point that as you've inserted your nasojejunal tube, and you can use fluoroscopy to find the tube and direct your EUS scope towards the nasojejunal tube. So I think that's a very important tip. Manu, if I can ask you, we've identified, we have infused sodium chloride, and now we've got a dilated small bowel. Can you give us some tips and guides in terms of what should the settings be for the hot axios? Should we be careful in the type of setting that we use? And are there concerns about using pure cutting current, or what are the guidelines say about the settings of the current?
So that's a very good question. Actually, I don't think that neither Marc nor I did it mention. So it's good that you bring this up. High power settings, so effect 4 or 5, no coagulation, and high wattage. So typically, the manufacturer recommends 100 watts, effect 4 or 5, depending on your cautery source. But for gastrojejunostomy, we even increase the settings to 130 or 140. What you want is your hot catheter to burn through the wall of the small bowel instead of going tangentially or pushing it away. So it's important that the settings are very high, no coag, just pure cut, and that way we minimize the risk of peritoneal deployment, because not going deep into the bowel. So also you have to move hot and slow. You cannot do like FNA very fast. You have to keep going and monitor the tip, because it's been reported that you can injure the contralateral wall. So that's not one of the misdeployment, but is another adverse event that can occur. finally, it's very important to have a very well distended small bowel. So it's only halfway distended. The risk of pushing the small bowel away is higher. So you really need to have well distended. If you are going to do it freehand, as shown by Dr. Barthet, you can, when in less distended settings, when you cannot put a tube for irrigation, you can have the wire and go over the wire. But if you go freehand, you need to basically transform the small bowel into a distended gallbladder or a pseudocyst. And the final precaution is you have to look for intervening loops of bowel. So piercing of the colon and the small bowel has been reported. So that's another thing that we did not mention, but it's important. So, and if in doubt, you are not stable, you cannot be 100% certain this is the small bowel, you can always abort the procedure instead of going when you are not certain. So there's always, you can always go back to a duodenal stent or call for expert assistance if the case, because not all cases are similarly easy. So it's better to start with easy cases.
I agree. I think that's a very, very important point. Mark, if I can ask you. Yes, of course.
Just to add something to Manuel, I fully agree with Manuel. The key point is the setting of the electrosurgical unit, pure cutting current, high power, no coagulation. I just want to add two things. The first is the use of hypokinetic drug, like a glucagon or buscopan. This is very important because you have not to have any movement of the small bowel. And the second point is when you apply the current, you don't push and then apply the current. You apply the current and after you push. If not, if you push first, you push away the small bowel.
Very important points. Thank you for that. The next question that also comes from our audience, the audience asks, is it necessary to use methylene blue, and for what purpose does it serve? So Mark, do you use methylene blue, and how does it help you?
No, in fact, I started with methylene blue. Finally, it was not so helpful for me, and now I use only saline and contrast. And so when you have the small bowel filled with saline and contrast, when you do the gastroenterostomy, you have as soon as you do that, you have a lot of fluid coming out from the small bowel inside the lumen of the stomach. So it's easy to see that. So I don't use anymore the methylene blue I used. It was an advice from Manuel. I worked with him, and I did that for my early experience with West technique, and now I don't use it anymore.
So the advantage of the methylene blue is that you open the proximal flange in the stomach and you see a lot of blue coming, which is easier to see than just clear saline and contrast, is more obvious. You are certain that you deployed correctly the stent. So I agree that if there's a colleague in Spain, Jose Carlos Subtil, who connects the nasobiliary tube to the tap, water tap with an adapter, so it has huge pressure. So he has a jet into the stomach. Of course, if you do that high volume, you need to do the patients under intubation, which we don't do routinely in our unit. So we just inject 200, 300 cc, 400, and we can always aspirate. So we like to see the methylene blue before dilating the stent. And sometimes with the EUS scopes, they don't wash the lens that efficiently as a gastroscope. So sometimes the endoscopic vision is not great. The lamps that are available, visibility on fluoro is not always great. So methylene blue provides instant confirmation of proper placement. But I agree with Mark, it is not indispensable. So the way we do it is we connect to the pump, to the tube, and after we deploy the distal flange, we disconnect from the pump and just give a syringe of methylene blue. Initially, we put some contrast, then connect to the pump with pump with saline, and then methylene blue. But it's very easy, so it only takes a second. But and I would recommend it in the beginning because if you don't see methylene blue coming backwards, then you can pull out the lamps with a small orifice. It will only be a 10 French orifice. But if you don't see a lot of fluid coming back, maybe the fluid that you injected is gone into the distal jejunum. And if you don't have, for whatever reason, the tube may dislodge. And if you no longer have the ability to inject, you may have to dilate the SEMS to see endoscopically whether you created, and then you will have a much larger hole. But those are secondary points of the technique, not the critical one.
Manu, you also touched on an important point, and that is that there is a difference in opinion, and I think we also discussed this at length during our EUS-GE guideline committee meetings regarding if patients with gastric outlet obstruction should be intubated versus if they can undergo the procedure safely without intubation, just with sedation. You've touched on this, but can you just expand on that? What are the concerns about a patient with gastric outlet obstruction, the potential for aspiration during this procedure, and if someone starts doing this procedure, will there be an advantage for doing these cases under general anesthesia?
Well, definitely there is a potential for aspiration, and especially, you know, I said that I think it's no longer acceptable that one starts doing this just by themselves. First case, so it costs nothing to visit if you are in France, Marc, in the South France, in Paris. There's a lot of people in many European countries we have learned the hard way, the wrong way. We've made mistakes that our fellows are not going to make. So intubation or endotracheal intubation certainly is very helpful in the first cases. And then there is wide variation in the policies for sedation in complex endoscopy. So every hospital should go their own policy. What I say in Spain, we can have propofol sedation by fully trained endoscopists. So we don't need an anesthesiologist in the room. And like other European countries, Germany, Switzerland, Austria, but that's not the case in other countries. So you need to have patient very well sedated. It's like pseudocyst drainage. Do any one of us these days thinks it's mandatory to have the patient intubated with the stents we have? It's a 5-minute procedure. You can take precautions like suction. So I don't know. I mean, it's certainly helpful, and I would say in the beginning it has to be done that way, but it depends on individual policy. So it's always good to bear in mind the risk of aspiration.
Shall we hear Marc's view? Marc, what is your view on this?
But in fact, in France, the problem is with the anesthesiologist. So they completely refuse to do any therapeutic EUS, and especially when you have gastric outlet obstruction without tracheal intubation. So we have no choice. So as we want to continue to work with the anesthesiologist, we accept in all the cases tracheal intubation. I fully agree with Manuel that when you experience it can take 5, 10, 15 minutes more at the maximum. But in fact, we cannot decide. This is if we want to try to work with the anesthesiologist, we have to accept tracheal intubation for any therapeutic EUS. So now the anesthesiologist agreed to work with us for any endoscopy. I know we have in France a lot of anesthesiology for general anesthesiology for any interventional procedure, but as we want to continue to collaborate with the anesthesiologists, we have to accept tracheal intubation. I fully agree with that. When you are experienced, it's not required in all the time. But
I think, Marc, maybe that is the point. I think that our audience should know that if you're very experienced, like Manu and yourself, I think it is it is possible to do it under sedation only. However, I think if you're less experienced, there is a potential risk of aspiration. And I think under those circumstances, rather start off with patients being intubated because it protects the airway and it's safer. And it's certainly maybe the way to start. And then one can evolve to a setting where you are comfortable doing it under sedation only. There's been one question from the audience about why do we use lumen opposing metal stents, Marc? Why don't we just put in a fully covered stent that is available? Why should we use lumen opposing metal stents when we perform these procedures?
This is a good question because at the beginning of the experience, some of the series used a fully covered stent and not LAM stent. But the advantage of LAM stent is to have flange, pushing together the wall of the jejunum and the wall of the gastric wall. And as we have a lot of research works with NOTS procedure, we clearly see that with the flange, it's pushing in close relationship the gastric wall and the small bowel. And after 1 week, you have a close adhesion of the two walls. So this is to keep the wall together, close together. Because after, if you use a regular stent, a long colonic stent, for instance, fully covered, you have the risk of dislodgement with the peristaltism of the stent outside of the small bowel or of the gastric wall. So for me, we have no other challenge for using any stents than LAMs.
Thank you for that, Marc. There's a very interesting question from one of the audience members that asks, what about this procedure in patients that are still potentially surgical candidates, but present with gastric outlet obstruction? Is there some evidence that support the use of this technique in gastric outlet obstruction, bridging patients to surgery? Mano, would you take that question?
Yeah, I don't remember now if there is any published experience. It must be anecdotal, if anything. We've had some cases and before Whipple, and the surgeons are happy because the stent is away. I mean, it's at the tride, so it doesn't interfere for the Whipple. So it can be done, but you need to talk to your surgeons and they have to agree to it. So it's a multidisciplinary team discussion. I've also talked to endoscopist, pancreatic surgeon, which is Rusty Kunda, and he does that routinely. But of course, for him, it's very easy to make an agreement with the surgeon because the surgeon is himself. But it's technically, it shouldn't be a problem, but it's something that has not been done. Therefore, it raises, there is this surgical principle. If any difficulty is experienced during surgery and the patient has had an endoscopy before, then the blame goes to the endoscopy. That's a basic surgical principle. I mean, it's not based on evidence, but is everywhere the same. So you need to talk to your surgeons.
Well, I think that's a good point.
I fully agree with Manuel. I just can add, not in gastric outlet obstruction, but with gastric bypass, because we are working with endoscopic gastric bypass for obesity, and the surgeons are pleased when we switch to surgery to have the previous endoscopic gastric bypass, because they have the place of the gastrointestinal anastomosis. And for them, it's very easy and more easy for doing the surgical gastric bypass.
So you are doing gastrojejunostomy, EUS-guided for obesity?
No, not EUS-guided, with NOTS, because
NOTS.
With NOTS.
So you go distal into the small bowel.
Yeah, because we have a device to know the distance between the pylorus and the part you want to target to do the bypass. So 1 meter.
Very, very interesting.
Yeah,
it's a fantastic concept that I think we should discuss in the next webinar.
Yeah.
Can I ask, Marc, will you take the next question? there's been some questions pertaining to in patients where a gastroenterostomy lumen-opposing metal stent has been placed, but these patients tend to live longer than expected, with indwell times exceeding 6 months or a year, or in patients with benign disease where you use this device. Is there an indication to systematically change the stent to prevent overgrowth?
Schalk, this is a very difficult question and very difficult to answer because we have no literature. We have only our experience. So actually, we have about 1/3 of the patients with benign indication for gastroenterostomy. From this experience, I can say you have not to retrieve the stent before 6 months, and the best is do not consider to have any exchange before 1 year. And what I saw at 1 year, the stability and the ingrowth is okay. We have no real problem with lamp stent, and if you have, you can do the stented stent technique to remove it without any problem. So what I do, I wait for 1 year, and after I remove the stent, and after removing the stent, I look back the patient 3 months later to be sure we have not a tight stenosis. But if you do that before 1 year, you will have a tight stenosis and sometimes a complete closure of the gastroenterostomy. So this is why I tell you, don't do anything before 1 year. And at 1 year, you can remove the stent. And after you take back the patient 3 months later, and you look if you have a tendency to stenosis or not. If you have a tendency to stenosis, you can do dilatation or insert again a new stent.
Okay, that's some very good advice, Marc. Thank you. Maybe I'll take the next question pertaining to ascites. I think Manuel very clearly described the issues with ascites, that it makes this procedure more difficult. But I think that I have very strong views on this, and it stems from the fact that not only is it more difficult, but I think it is also what you will achieve in a patient with extensive peritoneal disease by placing a lumen-opposing metal stent in such a setting. And I think what you referred to, Mano, was that great article from the group of Sandeep Lakia from India, where they showed that although it's technically possible, the survival was only 36 days in this group of patients. So I think that, in my opinion, we should be very careful to place gastroenterostomies in patients with ascites. If the reason for the ascites is portal hypertension, there may be an indication, but there we require pre-procedural drainage. And I would be very hesitant to place gastroenterostomy in patients with malignant ascites, given studies that now clearly show that the outcome of these patients are very poor. So you're going to put these patients at risk without much gain. So do you concur with this? Are there different ideas regarding the management of these patients with ascites?
Yeah, overall, I concur with you. However, we should distinguish large volume ascites, massive peritoneal disease, to small amount of ascites.
Sure.
This is common in patients with pancreatic and antral malignancy. So small amount of ascites is no. But even then, so we've seen patients with a very limited life expectancy, that the ability to eat, you know, for doctors, we tend to underestimate this patient is only going to live 30 days. But 3 weeks at home, being able to eat, it makes a whole of a difference. But I agree, it's riskier and risk of misdeployment, and then you kill the patient because the patient clearly non-operable, or risk of peritonitis. So you should discuss, you should only consider these patients after you've gone over the learning curve. And for that, let's take Mowinka-Shab study at 25. That we always need like a number as a reference. Let's use the 25 successful gastroenterostomies before you do such first cases, and always informed consent, careful discussion. Because what is the alternative? NG tube, percutaneous gastrostomy, venting gastrostomy. So If I am that patient with malignant ascites, I will have paracentesis and have gastroenterostomy done by expert operator like yourself or Marc, instead of having NG tubes. But it's a special situation, yes. And
Absolutely.
Yeah.
Then there are a few questions on pertaining to complications and the recognition of complications. Specifically, we've spoken about how to recognize potentially, and I think Marc and Manu, you both made the point that it's very important to recognize a complication while you're busy with the procedure. It is detrimental to the outcome if the complication is only recognized afterwards. So can you spend just a few minutes on, Marc, maybe explaining on what steps do you undertake following placement to make sure that your stent is in a good position, that you don't have a complication? Are there anything special that the audience should know?
Okay, I think the use of methylene blue at your beginning experience is very useful, because if you have a reflux of methylene blue, you are sure you are in the small bowel where you have no problem. So first, what I do, I stay in front of my axial stent after opening, and just an advice: take care when you are retrieving the nasobiliary tube. Take care, because if you have any loop around the distal flange, you can dislodge your stent. So take care to that. So I stay in front and I look if you have any reflex of saline, contrast, and methylene blue if you use methylene blue. And after I inflate and I look on endoscopy and on X-ray if I have air going into the small bowel, feeling the air going into the small bowel, and I look to the mucosa. I can see throughout the axial stent. So in such case, you are sure the anastomosis is okay. If you have any doubt, use a catheter with a guide wire. Push the guide wire, push the catheter, and after you can inject some contrast by using the catheter. But take care not to pushing too much away the small bowel and displacing the stent.
Manu,
This is my advice.
Yeah, I think that's very good advice. I'm going to ask you a difficult question, Manu. You've placed your gastroenterostomy lumen-opposing metal stent, but you are concerned that your stent is not, the distal flange is not adequately deployed in the small bowel, but you're not sure if the small bowel was damaged while you place the stent. Are there ways to exclude a type 1 and a type 2 complication, because the management may be quite different?
I don't think there are very reliable ways to do that unless you salvage, or unless you don't, and then the surgeon goes in and takes a look. I mean, I assume you mean during the endoscopic, but if you salvage, I mean, if you suspect that your distal flange, or you're certain that your distal flange is in the peritoneum, the easiest way out is to remove the lamps. Use a clip, a large over-the-scope clip, place an enteral stent, put an NG tube past the duodenal stent, and put the patient on antibiotics, analgesia, and hydration, and watch closely. But if you decide to go and salvage, let's say you are an expert like yourself, you've done your 25 or even 40 cases, so you reach mastery, and you're teaching your fellow, and let's say your fellow misdeploys, then you can go balloon dilate, do node salvage or over-the-wire salvage, and then if you place another lamps, you can go with a pediatric transnasal gastroscope, or a standard, not therapeutic, standard upper endoscope, gastroscope, and use contrast, see if there is any leakage. But if you've used contrast before through your MB tube, or, I mean, the field is usually muddy, so you don't see leakage very clearly unless you have very high-end fluoroscopy. So endoscopic inspection, And then, but even this is, I'm not sure how often type 2 happens. Usually, what is called type 2 is that you are certain that the tip of the hot lamps is inside the small bowel, but not deep enough. And then when you deploy, because most lamps will come backwards, the tip is inside, and you've seen that under EUS, or maybe you know because you use a wire or you put some contrast. So you are certain that your tip entered the small bowel, but then somehow your distal flange comes backwards into the peritoneum. Then this is definitely a type 2. And then you need to salvage, and you may attempt to do the nasojejunal tube, antibiotics, and watchful monitoring, but the threshold for surgery should be very low. I mean, if the patient is not improving within 12 hours, 12 to 24 hours, you should call your surgeon, possibly your best surgeon friend.
That's a very good
surgeon.
point. I think we're running out of time. I think all of us could have spent the next hour talking about this interesting topic, but I think we will have to unfortunately move on. I'm sorry if we could not have dealt with all the questions that that you pose. So in the final talk, we'll ask Marc to address us with some very interesting, novel uses and a view of the future. Marc, if you can enlighten us.
Okay, I will try to be short. So the first one is the EDI procedure. You saw the speak by Manuel. So it was a patient with Roux and Y anastomosis, and so it was not possible to do hepatic gastrostomy in this patient. So we decided to do the EDI procedure. So meaning that we are going to do gastroenterostomy anastomosis with the direct technique, of course, because you cannot reach the afferent loop. And after you push the lamp stent, you open the distal flange, and after you open the proximal flange, and you have to do a two-step procedure, of course. This is required to avoid any dislodgement. And after doing that, you can go back 1 to 2 weeks later and passing through the gastroenterostomy to go into the small bowel. So I show you the procedure. Just it was 1 month later. It was a patient with metastasis at the level of the hilum of the liver, and so you see the lamp stent which is deployed, and so you can enter inside, and after you go inside the small bowel, you see the clip, you see the aerobulia, and you will see the biliary anastomosis, you see, with regular gastroscope, and you see now the digestive anastomosis with the remaining bile duct, and so you can after push a guide wire. And in this case, we do like for cholangiocarcinoma, we put 3 stents to drain the patient. It was very easy to extend the stent because in daily procedure because of the gastroenterostomy. And this is a Candy-Cane syndrome. This is a patient with esophageal anastomosis after total gastrectomy, and the patient has a blind limb which was too long with sequestration of the food, and so we decided to do jejunal anastomosis through the blind limb and to connect the blind limb to the efferent limb. So you see all the saline with contrast, and after with the EUS scope, you go into the blind limb and you find the efferent limb to do the connection. So you can use also the West technique, and by using a nasocatheter. This is I filled with injecting contrast the efferent loop, and so you see I will do the West technique now. You see, okay, you have the Bollenstein, and after you of course you open your distal flange about 2 centimeters downstream to the entering point, and after you retrieve, and you will deliver the proximal flange, and so you will have the jejunal anastomosis just below the esophageal anastomosis, surgical esophageal anastomosis. This patient was not able to eat anymore with complete food intolerance, and after he gained weight, and it was okay. You see clearly the mucosa of the jejunum in the efferent limb. And so I just show you the result 3 months later. The patient had the weight gain 10 kilograms. And you see we are into the esophagus. And you see we reach the esophageal anastomosis. And you will see, okay, you see in the blind limb, you see the lamp stent, and you can pass very easily inside the efferent limb. This is the treatment of the Candy-Cane syndrome. Now I show you indication in a complicated bariatric surgery. This is a diverticulum after sleeve gastrectomy. We have more and more cases of fundal diverticulum because the surgeon tried to avoid to resect too much the fundus in sleeve gastrectomy to avoid fistula. And so you put a nasobiliary tube inside the stomach, and after, okay, you see with X-ray, after the goal was to go into the diverticulum, to fill it with contrast, and to look with the nasogastric tube, the position of the downstream stomach, and to do a gastrogastric anastomosis, like for afferent loop syndrome or like for any gastroesophageal anastomosis. You see, we apply some current just before going inside the lumen of the downstream stomach, and you see after is as usual you release the distal flange distally from the gastric mucosa. You pull back a little bit, you apply your distal flange, and after you open your proximal flange. You will see it very easily. So we can do that also for gastric twist after sleeve gastrectomy. It works very well. I did that 2 cases this afternoon. It works because balloon dilatation is not working at all. And so you can use this technique also for treating gastric twist after sleeve gastrectomy. So we try the device. You see, we have the guide wire inside, just for safety reason, to be sure we are in place. And I will show you what we did 1 month later. Oh, sorry. Okay, so you can see clearly. You can see my arrow or not? So you see on the image, you see the stent, and after the goal was to cut the septum, which was just upstream above the body of the stent. So we cut with a dual knife completely the septum until we reach the stent, and after the stent was going out of the tract, and you see you have no more diverticulum because the septum was completely cut. So this is a very useful device, first to treat the patient, and secondly, you can completely remove the septum by cutting it and avoiding pneumoperitoneum or any leakage, because you have fibrosis induced by the insertion of the stent. I don't show you this video, I just want to finish because we are very late. This is a case, you show a very short series, Manuel, about it. This is a case of colorectal anastomosis in a patient with pelvic metastatic obstruction with carcinomatosis. And so I will show you the case. Sorry. Okay, now it's working. So you see the CT scan with the small bowel, of course, with complete obstruction. So we went into the left colon with after enema with EUS cup. You see the small bowel filled with digestive juice, and this is like a West technique. And after we of course we push the axial stent inside the lumen, the lamp stent inside the lumen of the dilated small bowel. Okay, you open your distal flange. Okay, you retrieve it a little bit in close contact to the jejunal wall. And after you switch to the colonic lumen, you see the opening of the distal flange into the jejunum lumen. And after we will move to the image, the endoscopic image inside the lumen of the colon, and you see the juice, the digestive juice, coming from the small bowel inside the colon, and the patient has had no more symptom of obstruction, of digestive obstruction. And so he underwent again chemotherapy, you see. Okay, and you see the CT scan just 1 week later, no more dilatation of the small bowel, and you see clearly the position of the small bowel in between, the position of the stent in between the small bowel and the colon. So you can have a lot of indication, you can imagine a lot of things. Actually, we are working a lot about the indication in case of complication of sleeve gastrectomy with diverticulum or with esophageal anastomosis or with a twist, and it's working very well. We are making a series about it. So just the only limitation is your imagination and also your experience, because you have to be experienced before extending the indication of gastroenterostomy anastomosis. So thank you for your attention.
Thank you so much, Marc, for those very interesting videos on what may become the future as well. Maybe just a point to finish off on, and that is that these procedures should be done under antibiotic prophylaxis. We haven't emphasized that enough, given that we are bridging the peritoneal surface, especially in the presence of ascites. And I'm sure, Marc, in your case, that was also highly necessary, given that you drain through the colon into the small bowel and want to avoid bacterial translocation to the peritoneum. So I think we'll probably have to stop. Unfortunately, I want to thank our excellent speakers. They were truly amazing. We learned a lot through their discussions and their talks. And I hope that we can repeat this in the next months on a new topic and on a new indication. Thank you so much.
Thank you very much. Bye-bye. Bye-bye. Thank you.